we are live.
Okay. So good evening, postgraduates, and a happy independence to one and all present over here today. Let us on this Independence Day pledge that our country, India, comes out of the dark clouds which are hovering over the medical fraternity. And I'm very sure with the youthful spirit of all our postgraduates, their enthusiasm and their dignity and their pride, I'm sure we will have good days and a coming new year well. So once more, let me welcome you all to this 56th episode of All India Postgraduate Teaching Program, an initiative from ARC AOS. We call this postgraduate program, we try to identify it as a PG program with a difference because it tends to cover some uncovered aspects of other teaching programs like case presentations, journal clubs, OSCEs, and sometimes didactics on topics which are not comprehensively available for them at a go in a textbook. Today is the 56th episode of this series and the 11th Journal Club in last 1 year. Today's Journal Club would be presented by Dr. Venkatesh M., who is a junior resident at Lotus Eye Hospital, Coimbatore, and Dr. Shwetang Sinha, who is a junior resident at RPC, New Delhi. I'm thankful to mentor Dr. Ashish Sharma, who is a senior vitreoretinal consultant at Lotus Eye Hospital, and my dear younger brother, Dr. Rajesh Sinha, who is a professor of cornea, lens, and refractive services at RPC, Delhi. Of course, my special thanks goes to all the three senior discussants who have spared this valuable evening on this particular, almost a holiday for most of us. Dr. Jay Chablani, who is a professor of ophthalmology at Pittsburgh and a very dear friend of mine. Dr. Bhaskar Srinivasan, who is a consultant and medical director at Code from Chennai, and Dr. Rishi Swarup, senior cornea consultant from Hyderabad. We will be missing Dr. Rishi Swarup because of some unforeseen medical emergency in his family. But thank you, Dr. Rishi, for having agreed for this particular program. As Dr. Rajesh Sinha has requested, we will be slightly shuttling the case. First, we will be having the case by Dr. Shwetang Sinha, who would be presenting a case on cornea. So without much ado, can I request Dr. Shwetang Sinha to share his screen?
Yes, definitely. Is my screen visible now?
Yeah. Make it a full screen.
Yes. Yes. Shall I start, sir?
Please do.
Okay. Good evening, respected panel members. My name is Dr. Shwetang. I'm a junior resident at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. So the article that I'm going to discuss today is titled Corneal Collagen Cross-Linking for Progressive Keratoconus in Pediatric Patients with up to 14 years of follow-up. This article was published in the American Journal of Ophthalmology in November 2023, which has an impact factor of 5.26. Now, collagen cross-linking with epithelial debridement is a well-established treatment for keratoconus, and as of now, it remains the gold standard treatment for progressive keratoconus. However, there is still uncertainty regarding its long-term effects and the longevity of the structural remodeling that it achieves. Also, there is no consensus definition of keratoconus progression in patients who have already undergone CXL. And especially in pediatric subjects who the severity of the disease at diagnosis tends to be more severe, and they usually require a corneal transplantation earlier than adults. Because of these factors, the investigators thought of carrying out this study with the aim of evaluating the long-term safety and efficacy of collagen cross-linking according to the Dresden protocol in a pediatric population with a long-term follow-up of minimum 10 years and a maximum of 15 years.
Yes.
Yep. Go ahead, Shwetang.
Yes. So it was a retrospective, single-center, non-comparative interventional study with 38 eyes recruited from 24 patients who had progressive keratoconus, age less than 18 years. The minimum age was 9 and maximum age recruited was 17 years. And these patients underwent Dresden protocol CXL, collagen cross-linking, between June 2007 to January 2011 at the Humanitas Clinical and Research Center in Italy. The criteria for diagnosing progression pre-CXL that the investigators used was the Italian National Health System criteria, which defines progression based on differential maps demonstrating a change of curvature in the area corresponding to the conical component of the cornea with a magnitude of 1 diopter, or a reduction of more than 20 microns in the minimal pachymetry. Now, I would like to highlight at this juncture that in this criteria, they have not specified what was the time period in between this magnitude of change in the parameters needs to be noticed. So this is a small demerit in this criteria, that the time period has not been mentioned. Anyway, the inclusion criteria that they used was the documented progression of keratoconus according to the criteria that I just mentioned, informed consent, and corneal pachymetry greater than 400 microns. Any patient with history of previous ocular surgery or concomitant ocular disease or systemic disease was excluded. Also, patients who had used rigid contact lens for more than 4 weeks before the baseline evaluation were also excluded from this study. Clinical assessment, the baseline assessment was done on the day of surgery. The best corrected distance visual acuity, the corneal topography and tomography, and also the densitometry using the Scheimpflug imaging system, commercially known as the Pentacam high resolution system, was done. The follow-up examination was done at 2 points, one at the 1 year follow-up period, and the second at the late follow-up, which was at least 10 years and maximum of 14 years follow-up. The investigators defined the study endpoint as documentation of reprogression after at least 10 years of Dresden Protocol CXL. And the reprogression in this study was defined based on the ABCD progression display of Pentacam. Now, I would like to elaborate. The ABCD progression display of Pentacam is a system in which A stands for the anterior radius of curvature, B is posterior radius of curvature, C is the pachymetry, and D is distance visual acuity. Now, the investigators define reprogression if out of the following 3 parameters, any 2 was present. First, the progression of parameter A, which is anterior radius of curvature, beyond the 95% confidence interval, which was calculated for a post-CXL population, or an absolute value of A increase by a value of 0.261, or a progression of parameter B, again by more than 95% confidence interval, or an absolute increase by 0.208. And the third parameter was reduction of the minimal pachymetry of at least 7 microns, or again, in terms of confidence interval, if the patient fell outside the 95% confidence interval range. I would like to reiterate that the 95% confidence interval was calculated for a post-CXL population. The cross-linking procedure was carried out based on a standard Dresden protocol. 30 minutes before the procedure, painkillers were dispensed and pilocarpine drops were administered. This is done to constrict the pupil, which prevents the UV rays from penetrating into the posterior segment and causing damage. Epithelium was removed with Amoil's brush. The cornea was then soaked for 30 minutes with 0.1% riboflavin solution. Those patients in whom the intraoperative ultrasonic pachymetry demonstrated the thickness below 400 microns, they underwent hypoosmolar collagen cross-linking with physiological balanced salt solution to promote swelling of the cornea. Statistical analysis was carried out in a standard method with SPSS version 28, and the Mann-Whitney test were used for unpaired data. The level of statistical significance was set at p-value of less than 0.05, and refractive outcomes, as we will see further, the patient's manifest refraction was measured, and these refractions were analyzed using the method of Harris and Kay after transforming the data into Long's matrix formalism. This is a unique feature of this study because in most of the previously published literature, this Long's matrix formalism was not used, and this is a strong merit of the study because the Long's matrix formalism standardizes. It's a type of advanced mathematical vector analysis of the rays which pass through an optical system, and this allows us to fill any missing gaps in the refraction over time. When the patient is following up over time, if there is a gap in the data, we can fill that using a matrix formalism. It's an advanced mathematical analysis system. Secondly, it can also help us in avoiding the or compensating for the decentration of the optical system if the lens is decentered or if the cornea, the optical center of the cornea is decentered. So this stands out as a strong merit of this study. Coming to results, there were 38 eyes of 24 patients which fulfilled the inclusion criteria. The median follow-up time was 11.5 years. The mean age of the study population was 14.9 years, standard deviation of 2.2 years. The gender distribution out of the 24 recruited patients, there were 19 males and 5 females. And 45.8% of almost 50% of the patients who were recruited reported atopic symptoms. However, it is important to note here that none of the patients had significant general comorbidities, and as in the study, it is not reported that they were receiving or had received any treatment for their atopic symptoms. So it is likely that the atopic symptom was not very severe. The visual acuity and refraction results, the best corrected distance visual acuity was expressed in decimal fraction. As we can see in the box and whisker plot, the visual acuity significantly improved over time with the mean visual acuity value of 0.703 at baseline, improving to a value of 0.887 after 10-year follow-up. There was no significant change in the refraction with the p-value of more than 0.05. The investigators also carried out an aberrometry and showed that there was no significant worsening of the aberrometric parameters like coma or other higher order aberrations. The topographic and tomographic values as per the ABCD progression analysis, the analysis showed no significant change in the Kmax values, but it did show a significant decrease in the A value, the anterior radius of curvature, at the 10-year follow-up period, with the mean baseline value of 2.5, whereas the mean follow-up value of 1.6. Again, the pachymetry also showed a statistically significant reduction. And in this regard, the reduction was both as compared to the pre-op value, which was 486 microns, and the follow-up value was 440 microns, as well as if we compare the C parameter from 1-year follow-up to the 10-year follow-up, that also showed a significant difference with the p-value of 0.0002. So as we can again see in this table, the minimum pachymetry shows a significant change with the p-value of 0.001. Although the Kmax does not change, but the anterior curvature, anterior radius of curvature does show a significant reduction with the p-value of 0.019. The C value shows a significant reduction of 1.4 increase from 1.49 to 2.80, with significance of less than 0.001. As the aim of the study was to detect progression. So when we discuss progression, we note that out of the total recruited patients, there were 13 eyes of 11 patients which showed post-operative progression. Out of these 13 progressors, only 3 eyes had an increase in the A value. And even in those 3 eyes, there was a simultaneous increase in either parameter B or parameter C. So there were no progressors who had progression only in the anterior curvature. Out of the 13 progressors, total 12 progressors showed a progression in the C value, which is the pachymetry. And the mean age of the progressors was calculated to be 14 years with standard deviation of 2.2 years. The investigators also carried a subgroup analysis of atopic patients, and they found that there was no significant difference as compared to the non-progressors with respect to atopy. They carried out a densitometry analysis and showed that there is no significant difference between the first-year follow-up and the long-term, which is 10 years follow-up for the densitometry. But there is a significant difference with p-value of less than 0.001 if we compare the pre-operative densitometry value to the 1-year follow-up period. So in the early period of CXL, the densitometry value does improve, and this improvement persists up to a long-term period of follow-up, up to 10 to 14 years. Coming to the discussion part. So we'll use the Mari method for the discussion of this article. First of all, the study question. The study question appears to be well defined because the investigators have defined the aim of the study was to assess the safety and efficacy of CXL in pediatric age group. So they have well defined the pediatric age group. They have taken the cutoff as 18 years. Although it is important to note here that in the previous studies and also globally, the pediatric cutoff for pediatric age group is usually taken as 16 years. But in studies on CXL, previous studies have also, which was also done for a long-term period, previous studies has also taken 18 years as the cutoff. So we can say that the study question appears to be well defined in this case. They also defined the preoperative criteria for progression was defined well. They use the Italian National Health System criteria. But again, it is noteworthy that we do not have a global consensus for defining progression preoperatively. And the global consensus that we do have, it does not, that also does not mention any specific time period over which the change in parameters has to be seen. So based on the available data, we can say that the study question was well defined. Sample size, the sample size was small. There have been studies previously on similar topics in adult patients where almost 60 to 70 patients were taken and long-term follow-up was done. Whereas in our study, only 34 patients were taken. So it appears to be a small sample size, and the number of progresses also was significantly, apparently only 13. So we can say that it's a small sample size, and this precludes the generalization of the results of the study. Usually, if the sample size is small, the power of the study can help us in guiding whether we can generalize the study. But in this article, the power of the study was not mentioned. So again, we are at a loss here. And it is safe to say that we will need a larger sample to generalize the study results. Study population was well defined, but again, since it was it was a single center study carried out in Italy, it was an Italian population. So it is not clear that we can generalize the study to a global population. And as I mentioned previously, globally, there is no clear-cut guideline based on how much magnitude of parameter change within what time period should be classified as progression before CXL. So again, due to these reasons, the generalization of the study results is not reasonable. However, the study was conducted for a long time. The maximum period of follow-up was 14 years, which appears to be adequate. Assignment, the study was approved by the Institute Ethical Committee. They ruled that the formal approval was not required because it's a record review study, and the study was conducted according to the standards of Declaration of Helsinki. Investigators defined a very clear endpoint. They defined that the endpoint is documentation of progression based on the criteria that I mentioned, which is 95% confidence interval for post-CXL eyes. And this 95% confidence interval was calculated based on a previous publication that I had referenced in the previous slide. And I would like to highlight this important point that these investigators did a comparison not only from preoperative values, but also between the 1-year follow-up period and the 10-year follow-up period. This stands out as a very strong merit for this study because in the ABCD progression display system, the 95% confidence intervals are calculated automatically. And this 95% confidence interval has to be calculated for different populations, such as the pre-CXL population who are having keratoconus, or patients who are normal who do not have a keratoconus, or patients who are already undergone CXL. The normal and the keratoconic data was already available, but the post-CXL data, they have one of the investigators of this study has himself carried out a previous publication based on which the post-CXL data was collected, and the 95% confidence interval was calculated based on that. Now, comparing it not only with the preoperative data but also with the 1-year follow-up data is favorable because this negates the effect of the inherent noise of the testing system, which is different for the preoperative population and the postoperative population. So if we compare the data of a set of population post-operatively at 2 different points, at 1-year follow-up and 10-year follow-up, that rules out the any bias that might occur because of the inherent noise of the system. The clinical examination and the investigation technique were carried out with using standardized techniques. Coming to analysis, now there are certain important points that we need to note here. The investigators mentioned that the out of the 24 patients, there were 19 males and 5 females. So there appears to be a slight skewness in the gender distribution. But had there been equality, almost equal distribution, a subgroup analysis based on gender would have thrown more light whether progression of keratoconus has any gender predilection. Although previous publications have not reported this, but since we are already conducting a study, it is always advisable to do a subgroup analysis based on all the parameters. It could have reiterated the fact that gender predilection is not seen in keratoconus progression. The second important, I would like to say, a demerit in the study was follow-up periods for every patient was different. Some patients were followed up for 10 years, some for 11, some for 13, 14. But during the analysis, the entire bracket of 10 to 14 years follow-up was considered as a single point of time. So we don't know at the exact time of appearance of the progression, and we can only get an average idea between the bracket of 10 to 14 years when the progression appears. And again, as mentioned previously, those patients who had a thickness of less than 400 microns underwent a hypoosmolar CXL, but there is no subgroup analysis of these patients, whether they what is the rate of progression in these patients. So we don't know whether hypoosmolar and isosmolar CXL have any difference in rate of progression after the procedure. But as the investigators took 9 years as the minimum age for the inclusion criteria. So some of the children obviously must have gone general anesthesia, and some of the older children might have undergone CXL with topical anesthesia, but the subgroup analysis for what type of anesthesia was used and whether the patient was cooperative during the study, during the procedure, it is not specified in the study. But as I mentioned previously, a very strong merit of the study is that they use advanced matrix formalism methods to analyze the refractive outcome. And as we shall see later also, in previous studies, refractive outcomes have been shown to change post CXL. So the manifest refraction has changed. But in this study, it was clearly reported that refraction does not change post CXL, even in the patients who have documented progression on topography or tomographic analysis. So coming to the results, as mentioned, significant improvement in visual acuity over long term was noted, but it was not specified whether the best corrected visual acuity was taken on spectacles or contact lens. So that could have added to the merit of the study. But nonetheless, the topographic parameters showed A parameter increased only in 3 progressors, never alone. The C parameter increased in 12 out of 13 eyes. It tends to show that the A parameter tends to be more stable post CXL as compared to pachymetry. And Kmax showed no significant change. So we can interpret that the main outcome of the study is it reiterates that there is improvement in visual acuity post CXL, not only for the early period, rather the effect is sustained for a long-term period of 10 to 14 years. The mean follow-up period in our study was 11.6 years. So this is a sustained effect. And refractive analysis, as I've already mentioned, was also goes to show that CXL helps in disease stability. Another important point that they highlighted was in the progressors, although there is change in A value, which is the anti-radius of curvature, but there was no change in Kmax, which indicates that the maximum benefit of CXL, the collagen cross-linking, the mechanical benefit tends to occur at the thinnest point and not in the generalized corneal surface. Can we extrapolate the results of the study? There are certain factors that I would like to highlight here. First, as I mentioned, it is an Italian population, and the criteria that they use was also Italian National Health System criteria. So it is not clear that we can extrapolate it to a general global population. The sample size, as we saw, was small. But however, the visual acuity results and the results of refraction tend to agree with the previously reported results in the literature. So it's not completely in contrast with the previous literature. The aberrometric outcomes showed no change. This is only in partial agreement with the published literature. Some of the previous studies have reported that aberrometry changes post CXL, but this study showed that there is no change. Also, this study noted, as it was done particularly for a pediatric population, they noted that the progression reported is considerably higher compared to the adult population, likely because the pediatric population tends to have a more severe disease, and also because the incidence of eye rubbing in children, which is a known risk factor for progression, is higher in children. So overall, we can conclude that it was a good study, but the important we need to take the results of the study with a pinch of salt, because the uniform criteria for defining pre-CXL progression is not there. We need to have a well-defined pre-CXL progression criteria so that we can ensure that the patients who are being recruited into the study are uniform. And also, we need to carry out a multi-center study with larger sample size to find the patterns in the data better, and then we'll be able to generalize the study, the results of the study. Thank you.
Thank you, Shwetank, for taking us through a very detailed journal. Thank you, Shwetank, for taking us through such a detailed presentation of this particular article and trying to help us out with Mary analysis and all. So before I open it to the discussion, can I have some comments from the mentor itself, and then we can have some discussion, please?
Yeah, thank you, Shwetank. It was presented very well. Can you just unshare the
Yes.
slides? Yeah.
Yes.
So it is a good study, and in children particularly, it is many times there are difficulties in assessing, as well as difficulties in evaluating the patients. It's a good study, but yes, as has been pointed out, there are a few fallacies which I feel that they have included patients of hypoosmolar as well as isosmolar, but they have not specified that how many were hypo, how many were iso. They just said that the eyes wherein the thickness was less than 400, we just use hypo. So there is a difference in outcome in terms of in iso as well and hypo. So that is one thing. Apart from that, I think most of the things have been very nicely mentioned by Shwetank. There are few studies in pediatric age group. So this is one study. I would still feel that this will provide a lot of input in terms of doing studies with bigger sample size. And the rest, I think most of the points have been mentioned by Shwetank. So I felt that he has covered up and assessed it. That was the basic idea. The MARI method is the method that we should always utilize to review an article as well as to evaluate an article regarding its quality and the way it has been done.
Thank you, Rajesh. Dr. Bhaskar, Dr. Jay. First, let us have from the cornea man and then the researcher himself, Dr. Jay, as well.
Yeah, so as far as the paper is concerned, the merits of the paper is basically the most important part is the use of ABCD, because you're taking care of both the anterior curvature, the posterior curvature, the thickness parameters, and analyzing the outcome and the long-term follow-up. But there are certain flaws which are there. Now, when you decide that you want to use ABCD to define progression post CXL, you could have used the same criteria to decide your progression pre-CXL. Then you would have had a group where whatever 6 months, 8 months, because your initial inclusion criteria uses a different set of targets for defining progression, and your assessment uses ABCD has a pre-CXL data also with 95% confidence limit. You could have used that as a primary criteria to define your progression. One, you had almost about 14 eyes because it is 24 patients and 38 eyes. So almost like 10 eyes where they have not had a cross-linkage. Now, what happened to those eyes? Because those could actually be a very good comparison, because if those are second eyes of patients who have not had a progression, you will know whether the natural history of the disease itself is not progressing in these eyes, because keratoconus can be bilateral, it can be unilateral, asymmetric, and we do see some patients where we have done a cross-linkage in one eye and the other eye doesn't seem to progress at all. So telling everything based on cross-linkage might still not be an absolute truth as such. The most important part is, at least in terms of safety, you've not lost a single line of vision in the entire data, which is important. But these were a couple of things which I felt they could have actually added on to the information that we get. In terms of progression, we had our study which Dr. Prema Padmanabhan published in Cornea, where we had close to around I think 300 eyes of pediatric keratoconic patients, where we had analyzed, and our progression was close to around 20%. So it's not that it is less, but then the criteria at that time was Kmax. Criteria was not ABCD, which we are using now, because Kmax is not an accurate way of assessing progression in keratoconus. The other good point of the study was they used a 1-year criteria and then they compared it, because the first 6 months or a year, because of the haze of cross linkage itself, the value that you get from pentacam becomes unreliable. So if you look at a patient and do the pentacam in 2 months and 3 months, there's so much of scatter that your reliability of the machine itself gets better. So they've used the parameters correctly, but I would have liked them to have taken the data which is missing and analyzed it and given us more information of the safety and the outcomes.
Another important thing was that they never mentioned that with what they did the best corrected visual acuity, because progression was noted in 34%, but the visual acuity remained the same. I mean, it did not worsen. This
Yes.
means that, if there was a progression, they might have used, contact lens in some of the patients, but they have not mentioned anything related to that. What was the way they did the best corrected visual acuity?
Yeah, and the other thing was the B parameter also, the back parameter also showed a worsening, which I think Shwetank missed to mention in the thing. Back parameter and pachymetry values tended to worsen. The anterior curvature tended to be reasonably stable, except in those 3 patients where they actually saw a worsening of the anterior curvature. Now, this could probably be explained by the fact that your cross-linkage effect is more anteriorly, so you still have changes in the posterior, which is kind of happening, but your overall stiffness increases. So if they had added on a data about the biomechanics of the cornea into this, but obviously the data available at that 10 years back, they didn't have Corvus data available, but that would have added on more to know exactly what's happening, because now you do have the effect of with Corvus and Pentacam joined together, you are able to look at the stiffness in particular areas. So you can actually look at how the stiffness changes in the area of the cone versus the peripheral areas. So henceforth, when we are going forward, probably that would be something to look at.
And plus hypo and iso, they again mixed it up. And so it was a heterogeneous group. And they did not do a subgroup analysis between hypo and iso. So that was again.
Great. Thank you. Thank you for those. Some comments from Jay.
Thanks a lot. I'm not the expert, as you guys know. That is like, I know very little about CXL, and it's been a long time we saw that. But couple of things I can say about the presentation, overall presentation and the study design. And I think the purpose of this whole activity is that, we try to train our postgraduates how to plan your study design. And how to read a journal article. Shwetank, that was a fantastic analysis, and I was so happy to see that Mary on the screen. I said, oh, that's really a good step forward. So I think whoever is attending this program, the first message for them is to follow MARI guidelines. That is the way you look at any article, whether you're presenting within your department or anywhere else. It brings up really, it teaches you a lot how to look at the article. Some of the other things which I thought the study design wasn't great, but I understand the very question which was being targeted in this study was looking at the pediatric data. And I know that the pediatric CXL is very, very rare, and people must be surprised, whoever is listening, that how come you have 24 patients and still the paper gets accepted in AJO, right? Which is one of the prime article. So this is again another message that, whether you have a small sample size, but if you are trying to answer a question which is not being answered, the good journals will definitely take it. The other thing is that, like Dr. Bhaskar was mentioning, that these are the studies which will help us to build up the next study. So this is why it is important that, we don't ignore any of the studies which you think you don't have enough patients. You can always try to crystallize your question and build it up on top of that. And I think a very important part is that when you are planning a study, you should definitely look into the inclusion-exclusion criteria. And many of the points were already cleared by Dr. Bhaskar and Rajesh sir, that the lethality was not counted upon. That, how you included both when the disease itself could be different in both eyes. So we had to count upon that. And I'm sure that Shwetang must have hit the bar somewhere that if you're including two eyes, how can you do the statistics counting two eyes from the single patient? Because that itself creates a bias. So there are many things which we can learn from. Even, means I'm a retina specialist, it's totally not in my zone, but there are many things which we can take home and understand and plan our next study with much more clarity. And I think I learned a lot about CXL for sure. Thank you so much.
Thank you. Thank you, Dr. Jay, for adding those inputs. I think we have overshot the time. Now it's time for us to move on to the next presentation. And that would be a retinal article, and it is from Dr. Venkatesh, and he's from Lotus Eye Hospital. He's a first-year resident. So can I request Dr. Venkatesh to share his screen? And Dr. Shwetank, wonderful job done. All the big people have really applauded it. And as a first-year resident, you have done a wonderful job.
Thank you, sir.
Yeah, Venkatesh.
Good evening, everyone. Before I start, I thank everyone from AOS and ARC to giving me this opportunity. I thank Dr. Ashish Sharma, sir, for giving me this opportunity. So, So I'm Dr. Venkatesh Murugan, and I'm under the mentorship of Dr. Ashish Sharma, sir, from Lotus Eye Hospital Institute. I hereby going to present biosimilar ranibizumab BS1 early experience from Japan, bridge study. So before I proceed to the journal, I would like to emphasize on the InterBios group, which is being led by my mentor, Dr. Ashish Sharma, sir, which collectively tries to bring information about biosimilars from across the globe. The group has done a survey in India, US, and Europe, which were accepted for publication and are yet to publish soon. The findings from those surveys reveal that the clinicians rely more on the real-world data than the clinical trials about biosimilars. The group is actively gathering the real-world data from different countries, as there are only a few molecules have been approved so far in certain countries. So this journal I'm about to present today is about a brief real-world data about ranibizumab biosimilar 1, which is approved in Japan. This one is published in the journal The Eye, Nature, and it has an impact factor of 3.5. So this is the Indian real-world data along with Vitreoretinal Society of India, the anti-VEGF biosimilars for retinal diseases survey, and this one is BioUser survey from United States and Europe awareness survey. So let's enter to the journal presentation is. The aim of the study, the primary aim of the study is to get the efficacy outcome of ranibizumab biosimilar 1, which is assessed by visual outcome and central subfield thickness. And secondary aim of the study is to observe for any adverse events after biosimilar 1 injection. The introduction, the retinal diseases such as ARMD, diabetic retinopathy, retinal vein occlusion, and myopic macular neovascularization are the leading causes of blindness worldwide. So the anti-VEGF injections are very effective in retinal vascular and macular diseases. Though it has higher efficacy, it carries a higher financial burden due to cumulative need for injections, and it is the mainstay of the treatment. It's the mainstay treatment for these diseases. Anyway, recently ranibizumab biosimilar 1 has become available in Japan by Senju Pharmaceuticals, and this study was undertaken by that group, InterBios group. And here we report the early clinical outcomes regarding safety and efficacy in patients receiving ranibizumab biosimilar 1 injection for various retinal disease. So the methods, this study was a retrospective case series, which included consecutive patients with retinal diseases who underwent ranibizumab BS1 using 30 gauge needle between December 2021 to September 2023, conducted at Department of Ophthalmology, Toyama University Hospital, Japan. This was approved by Institutional Review Board, and a total of 205 ranibizumab BS1 injections were performed in 42 eyes of 36 patients with myopic macular neovascularization of 13 patients, and wet AMD in 5 patients, polypoidal choroidal vasculopathy in 6, retinal angiomatous proliferation in 12, DME in 3 patients, secondary MNV with angioid streaks in 2 patients, and macular telangiectasia in 1 patient. So the mean age The mean age was 70 plus or minus 18.7, which ranged from 29 to 91 years. And gender proportion was 58.3% of females. And mean follow-up, it was a longer follow-up, 47 weeks plus or minus 29 weeks. And the treatment naive patients were 38.1%, and pre-treated patients were 61.9%. And the mean number of injections ranged from 1 to 12, and mean was 4.95 injections plus or minus 3. So the inclusion criteria, there were no specific inclusion criteria were indicated other than the decline of visual acuity less than 6.6. And the exclusion criteria included vitreoretinal interface pathologies, media opacity obscuring vision, such as significant cataracts. And the results, the overall, the mean logMAR BCVA significantly improved from 0.37 plus or minus 0.44 at baseline to 0.22 plus or minus 0.32 at the last follow-up. In eyes with myopic MNB, the BCVA showed a tendency to improve from 0.29 plus or minus 0.41 at baseline to 0.14 plus or minus 0.33 at final visit, although the change was not statistically significant. In eyes with exudative AMD, the BCVA significantly improved from 0.31 plus or minus 0.32 at baseline to 0.23 plus or minus 0.3 at the final visit. In eyes with DME, the BCVA was 0.38 at baseline to 0.27 at the final visit. Overall, the mean the mean CST was significantly reduced from 240 microns at baseline to 188 microns at the last follow-up. In eyes with myopic MNB, the CFT significantly decreased from 239 microns at baseline to 180 at the final visit. In eyes with exudative AMD, the BCVA significantly improved from 210 to 115. 210 plus or minus 115. CFT was 330. In eyes with DME, the mean CFT was 339 plus or minus 175 at baseline and 367 plus or minus 183 at the final visit. To further understand the disease activity, the following changes in each fluid type was identified. Subretinal fluid was present in 22 eyes initially. By the final follow-up, there was complete resolution in 20 eyes, and one was observed partial reduction in one eye and no change in one eye. And intraretinal fluid was noted in 14 eyes at baseline. Of these, 6 eyes showed complete resolution, while the remaining 8 exhibited partial reduction in the last follow-up. So none of the eyes showed any signs of inflammation, vasculitis, endophthalmitis, vision loss, or any other ocular systemic adverse effects related to ranibizumab BS1. So these are the representative cases. So the first case of myopic macular neovascularization, it shows a dramatic reduction or complete resolution 4 weeks after one ranibizumab BS1 injection. The visual acuity improved from 2050 to 2025. So the second case of wet AMD with SRF at baseline and showing complete resolution at 9 weeks after just 2 injections, after 2 BS1 injections, the visual acuity was maintained at 2032. And lastly, the diabetic macular edema at baseline and showing complete resolution 4 weeks after one ranibizumab injection. The visual acuity was still maintained at 2020. So the merits of the study, the study was it has a longer follow-up. So it was like 49 weeks plus or minus 30 weeks. And the number of injections were significant. It was around 5 plus or minus 3 injections. And the limitation of this study was it was a smaller sample size, and there was it is a single center study. So the results were in agreement with the real world safety data and efficacy from the previous real world data from India, United States, and Europe. So, however, a long-term follow-up with a larger size is needed to thoroughly assess the potential rare adverse effects and ensure it's confident and widespread use. And patients who received ranibizumab BS1 injection showed no adverse events, and 50% cost reduction implies to replace ranibizumab with its biosimilar one in Japan. Thank you.
आवाज बंद करो. Hello.
Hello, sir.
Yeah, Venkatesh. Hello.
Yes, sir. Yes, sir.
Very well presented. Can I request Dr. Ashish Sharma for his comment?
Yeah, sir. If you are traveling, you can carry on. Me and Jay will take care. No problem.
Yeah.
If you are
No,
traveling.
I'm in a vehicle right now. Please go ahead.
Okay. Yeah, sir. No problem. So first of all, thanks to Dr. Prashant. Basically, the idea that Dr. Prashant, when he he asked me that, Ashish, I want you to have one of your resident present. So the idea was, Dr. Prashant, he explained that, we have a lot of residents across the country, and they find a lot of difficulty in starting their research career. So we have chosen a very simple article, brief communication, which any resident, especially if they are into retina, they can start their journey of publication with such kind of simple thought process and simple retrospective data collection. So you would find a lot of weaknesses in this, but still, you can start a journey because you do not require a great statistician for this. You can have your own basic simple statistics can be done with this, and means this would show you that how with the collaboration even you can bring up the global data as well. So do not worry about that part also, that I do not have enough data. So the message is that. And when Dr. Prashant, he asked that, who would present, I have all my senior resident attending a state conference, but I would congratulate Venkatesh. He's a brave boy, came up in his life with a lot of difficulty. He's first year primary DNB candidate. He presented for his capability well. So now I would request Jai, probably, because Jai, I am not sure, Venkatesh, you know about Jai or no. Means Jai is probably one of the best researcher that India has ever seen. So especially retina community, I can say, and he's a very close friend of mine. So I think more than me, I would request Jai to give his comments, and probably he would be a great guide for you.
Yeah. So whether Venkatesh knows or not, all the postgraduates who are watching us today, we have inspiring people like Dr. Chablani here, including Dr. Ashish Sharma, who himself has made us all proud. See, these are the people from our country who have made big in the field of research. So postgraduates, do watch them, get inspired by them, and that is the basic aim, that besides you learn how to present a journal, I insisted rather, Dr. Jai, to be part of this on this particular eve.
Thank you.
Dr. Jai, please.
Thank you so much. And really, Miss, it's an honor to be part of it, especially moderating along with the very good friend Ashish and Prashant San and everybody. So Venkatesh, it was really a great presentation, and I'm more impressed that you are a primary DNB and you have put together such a great in such a great way, and you got the message very clearly. And I think that's exactly what is needed. Talking particularly about the article, what Ashish said, that yes, there are a lot of weaknesses, but if you really think about the article, I think why do you think any paper gets accepted? Obviously, a great study, great question, but the very important message behind this article is because now we all know that biosimilars are important. It is becoming very, very important in our field of retina, where now most of the insurances here in the US are making mandatory that we do a step therapy with biosimilar and then get to the original molecule, because the cost effectiveness is the key, and obviously the burden on the system is quite a bit with these molecules. That's why the biosimilars are playing role. And I think India has done really a great work in biosimilar, and especially in retina. Ashish has contributed a lot on this. So I think talking about the paper, it clearly demonstrates that in spite of the weaknesses, why was it important to bring up this paper? So that gives our regulatory authorities the evidence that what biosimilars can do. And I think many times we have to publish just for that reason, that we can actually bring these paper and show that this paper is peer reviewed and has been approved by our peers, and then we should definitely push the biosimilar work forward in our country and support that. So yes, there are a lot of weaknesses. You can see that there's a mixed bag of the sample size. You have very limited sample size. You have a mixed bag of AMD, myopic, PCV, RAP. So definitely the whole idea behind this paper is that to show that yes, there are some impactful results with the biosimilar, which I think this paper is clearly demonstrating that. And talking about the future studies, I think this paper definitely sets up the platform where, we can think about the future studies using biosimilar. I'm sure Ashish also has done some of the work where, we can compare the biosimilars with the original molecule. One of the biggest concern is that, the safety and the initial results. And that's why Venkatesh correctly showed that, though the follow-up is only up to 48 weeks or lesser than that, but still it is important to know that how do we actually see the initial results with biosimilar, which I think this study clearly shows that. And one very important message comes out is that it is pretty much safe. And just to tell you guys that a recent biosimilar of aflibercept also just got FDA approval, and we have been
I'm so sorry, Jay. I think my network was off, so I have completely lost your comments.
Oh, that's fine. Nothing was important to you, Ashish. So, so I think that, now there are two biosimilars which we are already using in the clinic of Lucentis, but now aflibercept just got approved, so we are hoping that it's going to be around us very soon. Ashish, now that your network is back, we want to hear the expert comment.
No, you had to tell us our limitation, our weaknesses, our strength. That part probably that was completely missed.
Yeah, I discussed that. I'll just briefly say because you missed that, because I said the paper definitely has a lot of weaknesses. It is a mixed bag, small sample size. The treatment history was very much variable. The follow-up is variable, but the goal of this paper was to bring out the safety and the initial results of biosimilars, so we can definitely go to the regulatory authorities and say that, this paper has been peer reviewed and approved. So that gives us a lot of strength in terms of getting it accepted by the insurance companies, as particularly for the reimbursement. So I think this is definitely a big contribution.
Okay.
Yeah, Ashish,
So from my end, so from my end, basically, if you really look at means the strength, what I saw was the longer follow-up. What is happening in the biosimilar world is that, even if you look at the phase 3 trials, phase 3 trial design is a little skewed. So especially if you go to the countries like developing countries, India, or even if you go to Argentina, the kind of phase 3 trial design is completely different. If you look at the phase 3 trial design in India, you have a maximum follow-up of all the molecules till now is approximately 6 months, which is probably, is not a right kind of follow-up. And to be frank, even if you look at innovators, the kind of sample size that you need to detect the safety issues for an anti-VEGF therapy, you really cannot achieve that. So that is the reason that even if you look at even originator molecules or biosimilar molecules, the importance of phase 4 is really, really high. So post-marketing surveillance, which EMA and FDA both they emphasize upon, especially after the brolucizumab incidents. So that is the kind of data that is important. And I think in US, it becomes a little easier to get this data with your registries that they are in place, rather than the older way that we collect data from multiple sites, and then at least from the safety point of view. Any comment on that?
I agree, Ashish, because this is most of the industry sponsored trials nowadays. They are trying to continue collecting their post-marketing data set through their prospective registries, which I think is the future. And more important now is that because of the AI application, we are actually able to dig down all the way in all the electronic medical records and try to get this data. So I think the future is pretty much going to be like, kind of real life studies bringing into the evidence base, just because it is very expensive to conduct these clinical trials with billions of dollars. And I think the future is the registry data set and, most of the standard protocols which we follow in the clinic.
So probably, that brings us to another point, that what has happened in the past, if you look at UK, not ophthalmology, but in biosimilar world, if you look at a UK MHRA has already slashed phase 3 trial requirement. which probably, serves a purpose that, biosimilars are meant for a purpose to increase the access. And to increase the access, you ultimately have to bring the price down so that you can utilize that fund for your different, health issues, etc., into infrastructure, etc., whatever you want. And it's still, even although the clinical trial size is small, but still you have to invest, as Dr. Jay said. So you have a sizable amount of still economical aspect for that overall, getting a molecule approved is going there. So there is a lot of requests towards FDA and EMA, and I would not wonder that over the time, even in ophthalmology, you might not see phase 3 trials going on the way you have, post-marketing data getting validated with the help of AI. So I think most reliance might be on that, provided that you do the pyramid baseline pharmacoequivalence analysis, in the right way.
Great. Any other comments? Venkatesh, do you have any other thoughts?
So this is, this Venkatesh, I think this is your first presentation outside the institute. He is a primary DNB first year candidate. I mean, I would applaud you, for taking up the challenge.
Yeah.
That's
In fact, Jay, I think he really did his job very well. And in fact, both of you really complemented and supplemented and added to it what the other postgraduates should also learn from the article. Very well presented, helped us out in discussing. So I think if we have exhausted our discussion, it's time for us to wind up the today's show. And Jay,
Yes.
you can well continue. In fact, Ashish, you won't believe, Jay was so reluctant because it was his OPD time, and I had to really use all my tricks on the in that.
No, sir. And then I was a little scared though.
No, but the thing is, thank you, Jay. Be it whatever you have come out of your OPD time, and you have done a great job to the Indian community of students, whom people like you and Ashish can inspire, and that's the reason why I insisted you so badly. I'm
No,
sorry
and-
if I have rubbed you the wrong
No,
way,
no,
but
no.
thank you for being with us.
No problem. And I think that this is really a great start because I always feel that we have so much potential, and and like Ashish was mentioning, that there are a lot of people who want to do things but not being able to put together things, and I think these platforms are certainly going to give them the strength. I'll be always happy to be part, but one of the times when I'm not in the clinic, not a problem. Thank you so much.
No issues. Thank you for
Thank you.
helping out all the postgraduates and this next generation next of ophthalmology of our country. So thank you,
Thank
Ashish. Thank you,
Thank you,
Jay,
sir.
Dr.
Thank you, Jay.
Rajesh.
Sir. Thank you,
Thank
sir.
you,
Thank you,
Bhaskar, and
Prashant.
everyone, all the mentors, as well as both the postgraduates,
Thank you, sir.
Shwetank as well as Venkatesh, for doing a
Thank you.
wonderful job. We are so proud
Thank you,
of
sir.
seeing younger generations, such a confident generation. Trust me, when we were at your age group, probably we would have run away from this particular forum. But we laud your effort, your confidence, and we are proud of you. And we are
Thank
sure
you,
our
sir.
eyes will be in the next generation very safe. Thank you. And
Thank
best of
you.
luck
Thank
to all of you.
Shwetank, congratulations to you as well.
Thank you, sir.
Fantastic.
Thank you.
Thank you.
Yes.
Thank you,
Chalo.
sir.
So it's
Good night.
time
Good
for
night,
us to say
everybody.
bye-bye.
Bye.
Let's call it a
Sir,
day.
have a
Thank
good
you.
flight.
Bye-bye.
Have a good
Thank you.
flight.
Sir.